So as Owen said, I'm a part of the team at PHMC. We work together with Bradbury-Sullivan, as Christina said in her presentation, to gather the data, analyze the data, and put out a public-facing report for everyone, which you would have received every other year that we do this health needs assessment for Pennsylvania's LGBTQ community. I'm joined today by my colleague Heather, and there's some others in the room, like Rue, and I don't know if Katie and Jen, yeah. So thank you for being here. If you have any questions for our team, really any of us can answer, and we'd be happy to help your organization if you have any research needs that you want to use this data to look into. We can leverage that together. But today in this presentation, I'm going to focus on intersectional healthcare, kind of just how that framework of intersectionality can be seen throughout this data and what we might be able to advocate for using that. So I kind of just ran through some of this information. Yeah, this is funded by the Department of Health's Division of Tobacco Prevention and Control, and we get the data from a virtual survey that's bilingual. I guess that's the new information on this slide. And yes, basically the critical need that this survey fulfills is that public health planning need to understand what the experiences of individuals in the LGBTQ community are, and then through an intersectional lens, we can also look by group to see what differences of experience there are, because each response represents an individual at a different intersection of identities, and across these different topics that we get to ask about in the health needs assessment, there's a lot to explore. So I'm sure many, if not all of you, have heard a definition of intersectionality. It's a term that can be misused, so I'll just try to be clear about how we're talking about it today. This was developed by Dr. Kimberly Crenshaw. It's the interaction and cumulative effects of multiple forms of discrimination affecting the daily lives of individuals. And this was developed to talk about the discrimination specifically that women of color face. So, especially Black women. But in the sense that we're talking about it today, we can look at all kinds of factors that go into identity, not just LGBTQ plus identities, things like race, ethnicity, that's what's pictured here, but there could be far more, chronic illness, languages you speak, you name it. And so just as an example, if we want to look at one intersection, the one highlighted here is the one that would kind of explain the specific discrimination someone might undergo because of the crossroads of their sexuality, disability, race, and gender, whatever they may be. That can get really specific, the types of systems and the types of social norms that then are faced because of where you are at that crossroads. It's something we need to understand in order to serve all people, because we can't just say, discrimination is bad. We have to understand the specific types of discrimination to be able to get anywhere. So as you can see here, overall, 3 in 10 of our respondents in the just general PA respondent population who are LGBTQ have experienced a negative reaction from a healthcare provider when they learned they were LGBTQ. And we see something more like 4 in 10 as the percentage when we look at disabled folks, transgender respondents, respondents of color, neurodivergent folks. And that, to get into these categories a little bit more than what you could have heard from the bigger presentation earlier, our methodology for identifying if someone was a person of color was they self-identified. Same with neurodivergence, we asked them, do you identify as neurodivergent? And later they could select whether they did have any diagnoses. And then for disability, we asked a matrix that is used by different organizations that have recorded ways to track disability, but we use the scoring scale on that matrix that is used by the Washington group. So you can look that up if you're interested, but basically we ask about physical and neurological tasks and the difficulty associated with them. So having some difficulty, having a lot of difficulty, it's that kind of matrix you might have answered questions about before. And we would have had a different number of respondents count towards being disabled if we used a different one, but the Washington group one was actually the more restrictive one that we considered. So just goes to show that like a lot of people who wouldn't consider themselves disabled face difficulty in things, and then they are disabled depending on the way that you view the term. But that's how we went about that. We also see that while it's a problem that overall 1 in 5 respondents have not visited a doctor for a routine checkup in the past year, that's a much worse statistic for those who are disabled, those who are neurodivergent in our respondent population. More like 1 in 5. And this is just a pattern we see throughout. So here there's, okay, the groups didn't show up, but this is looking like a different PowerPoint than the last time I saw it, something about the conversion. But basically, it's the groups we've talked about before, and then that last group is supposed to be respondents 25 and under. Respondents 25 and under face a greater burden of fearing healthcare services. And these are like really valid concerns in many cases. It may have to do with their experiences, and it may also have to do with their perceptions. That's something that needs to be further studied. And then unstable housing, we asked about that, and in our definition of unstable housing, we counted whether you were unhoused, whether you had to do couch surfing or staying in a temporary situation because you had no other option. We had a definition like that. And unstable housing was more common among disabled people, people of color, transgender people, and neurodivergent people. This is any time in their lives, and that's the numbers I've depicted here. But we also have a question about in the last short period of time, and I believe that that was also significant to a chi-square with p less than 0.05. And then I want to infuse some qualitative discussion just because you'll see in the report that there are some open-ended responses, but this is mostly a closed-ended report. And we really want to understand the specific experiences people go through when we look through intersectionality. So out there in the literature, you'll find there's a lot of rich information about that identifies and evidences what it is like to go through a specific set of identifiers and culture and go up against these systems that are oppressive. So like in the Olivet et al. Paper, we hear from Black men who are also unhoused and see that that experience is different than that of other unhoused people of different genders and races, right? There's a specific racist system that over-scrutinizes applications because of racism. And that plays out through individuals, of course, but it's useful to look at it systemically. And then on the right, you'll see some art from an autobiographical qualitative study. And it depicts on the left kind of like white, stereotypical queer joy out in the sun, whereas LGBTQ plus people of color with different ethnic and cultural experiences that are in that norm are almost pushed underground, building roots but not seeing the light of day. And this has to do with a difference of experience that the writer, the artist, was explaining when they were creating their study and that they had gone through, and they've also heard from others. It makes coming out complicated. Same thing, well actually a very different thing, but related to coming out with those who have autism and are LGBTQ+. They are not having the same coming out journey. The respect that they want to obtain in coming out is not the same as when someone who is not autistic goes and comes out. There are studies explaining that experience. So this is hard to wrap up, but I'm at time, so we have some recommendations, and I'd love to hear what others in the room have to say when we're in the questions component. You can also just treat it as like sharing your wisdom. So we think a patient-centered model is really important here in order to understand an individual and where they are in these intersections. Know that it may be uncomfortable if you ask about the intersecting identities, and there are models like the Trevor Projects to actually be careful in doing so. It's something that really does bring up risk in certain cases, but also may help someone get the resources they need if they are willing to disclose what all of their identities are in that circumstance. And then if you're in the research landscape, or if you're a student and want to get into this, we encourage you to engage in more intersectional research, which will result in deeper understanding of all of these experiences. So that is all. I can pause on that for a second. This is our information. Thank you.